Thank you. I am very happy to be in this hall, and it is one of the most vibrant IMA branches of Tamil Nadu, IMA Kuttalam. And before about few years back, I was here in the same hall as a office bearer of IMA Tirunelveli branch. And so today my topic is mostly not just okay. So going to the topic, I am going to deal about spine, and I'm not going to talk about any spine fracture or spine tumor, just spine, and why the spine and why the MRI finding is not correlating with clinical evaluation, because our spine mainly meant to be walk with four legs. So our spine meant to be walk with four legs. When we started walking with two legs, we developed certain curvature, that is secondary curvature, that is the cervical secondary curvature and lumbar cervical secondary curvature. Our spine meant to be like this, and we are supposed to walk with four legs. Once we started with going in a erect posture, we developed some abnormality. So we started developing this secondary cervical curvature and lumbar cervical curvature, and these only creating so many complications, and almost 90% of people will develop some kind of spine problem. Spine simple. So most of the spine issues are simple and physiological, and it will cure on its own, may require some medications, and only very few or very less condition require proper intervention. So how, as a general practitioner, how we can identify whether it is simple spine problem or a complex spine problem. So this is a main slide. I want to convey this message. This is a main slide. Our spine has bony components and ligament, bone and ligaments, and from spinal cord, nerve roots will come out, exits, and spinal cord. These three components are in the spine. So bone and ligaments, nerve roots, and spinal cord. Any symptoms related to bone and spine, bone and ligaments is benign, nothing to worry. And anything related to nerve roots, you have to watch out, and you may require treatment. And anything related to spinal cord, it is very serious, you have to immediately intervene. So this is the main thing I want to convey. And MRI will show everybody, almost everyone will, if you take MRI for our spine, everyone will get some finding. Disc bulge, disc dehydration, disc or some degenerative changes will be there. So almost everyone will have some MRI finding. But how we approach the spine? Only by symptomatology, not by MRI finding. That is my main topic today. So we will see in a little bit about symptomatology now. Osteoligamentous pain is mostly, it will be local pain, neck pain or back pain. It will be dull aching, and most of us would have experienced one way or other. And radicular pain only it will have a radiating pain. Not only it will be there over the neck or low back, it will radiate to arms and legs. That is radicular pain. Nerve root, whatever nerve root get irritated, it will reflect on this dermatome or myotome. So it will be a dermatomal distribution. If a C5 nerve root get compressed, you will get a pain or numbness over the deltoid region. So that is how we can easily identify and localize the lesion. Lumbar, if L4 nerve root is involved, dorsiflexion will be weak, and L5 involved, extensor grade 2 extension will be weak, and S1 plantar flexion will be weak. So likewise, we can identify the patient is having nerve root involvement also, not just spine. Patient is having nerve root involvement also. That we can identify by in our clinics itself. And we can easily localize by symptom which nerve root are involved. If L4, L5 root is involved, and if the central paracentral disc involved, it will affect the transiting nerve root, that is L4, L5 disc. If the central paracentral disc is involved, if the disc bulge is paracentral, it will involve the transiting nerve root, that is L5. If a far lateral disc is there, it will involve the exiting root, that is L4. So clinically itself, you can find out whether the disc is paracentral or far lateral. So now you just, I am coming to the biomechanics. Just see how the mechanics change the anatomy. Whenever the spine is going for flexion, now it is flexing, you can see the disc space getting compressed. Now it is extension, it is disc space is widening. Now it is getting compressed. So basically, whenever the patient is having a spine, first thing is they have to avoid flexion, forward bending. Any procedure, anything you are doing by flexing your spine, you should avoid. That is the universal thing. So it is true for lumbar as well as cervical. So avoid forward bending is your first instruction to be given for any patient with spine. And normally we can see how the disc space, our posture affects the disc, our disc and spine. Lying down posture is the most comfortable position for a spine disc. Only 25% of pressure is there. Standing is neutral, 100% will be there. And sitting is slightly increasing your disc pressure. And sitting and forward bending is a maximum pressure that will exert on your disc. So whenever patient is having this degenerative condition, you should avoid sitting with forward bending posture. You have to sit in an easy chair with like a chair. Don't avoid forward bending and sitting. This posture is causing maximum pressure on the disc, and this will worsen your neurological condition. And most of the simple patient with will improve with activity modification, avoid forward bending, lifting weights, steroid, NSAIDs, weight reduction, core strengthening, lifestyle modification. That itself is enough for most 80% of spine cases. Some core strengthening, patient may ask, can I do yoga, can I do this and that? Nothing is allowed. Whenever patient is symptomatic, rest is very, very important. Avoid exertion when the patient is symptomatic. They can do some strengthening, paraspinal muscle strengthening stretches like these passive movements you can do. Avoid doing flexion or any exertion when the patient is symptomatic. Now coming to the most important, most dangerous part of the symptom, myelopathy. Myelopathy, whenever you find a patient, a spine patient with myelopathic features, immediately you refer to a specialist. Don't delay, and if we delay, patient will get permanently crippled or even bedridden. If it is cervical, patient will be bedridden. If it is lumbar, patient will be crippled with foot deformity or even bladder bowel symptoms lifelong, they may have to depend on assisted urination and assisted bowel evacuation. Because spinal cord has so many tracts, motor, sensory and bowel. So any condition that started compressing the spinal cord, immediately refer and don't delay. If the patient, don't worry, just give symptomatic management, and if the patient is having nerve root problem, you can also wait and watch, but spinal cord problem, don't wait. And meantime, you have to have some idea about differential diagnosis also. That this is a domain of Alayasan sir. So neurologists will deal with, they will be expert in diagnosing all these things. Not only compressive element, the patient may develop various neurological conditions like degenerative conditions, motor neuron disease, MA, and demyelinating diseases like multiple sclerosis, GBS, and peripheral entrapment. These also may mimic spine problem. That also we have to rule out before going for any intervention. Some condition like some people will have congenitally narrow canal. See, this is a normal canal with cardiac fibers sparsely distributed. When the canal is very narrow, everything will be crowded inside, and even a slightest disc bulge will cause symptom. So those patients, see, you can see the MRI of this patient where so much CSF space is there, whereas this patient, there is no CSF space at all. So such MRI patient may require surgery if there is any mild symptom. So that also we have to monitor. And such patient may go for Cauda-Equina syndrome for even a small disc prolapse. So such patient immediately need to be referred. Cauda-Equina syndrome will have a specific symptoms like urinary incontinence. Suddenly patient will develop low backache, and suddenly patient will develop urinary incontinence. Whereas osteoligamentous pain or nerve root, they won't develop urinary incontinence. When all the nerve fibers get compressed, patient will develop urinary incontinence, saddle anesthesia, bilateral leg pain, bilateral leg weakness. They should go for emergency surgical decompression. And how we decide when the spine has to be fixed or not? So we usually divide the vertebral spine into 3 columns: anterior column, middle column, and posterior column. Whenever there is more than 2 columns involved, then only we will go for surgical fixation. All cases with fracture, we don't need to go for fixation. And most of the surgery we do is laminectomy. That will involve only the posterior column. So that is why fracture involving anterior column alone, vertebral compression fracture, no need for any surgical correction. Not every spine fracture need to be fixed. So some specific list is also there. I don't need to complicate now with that. So take home message is, give priority to clinical evaluation over the MRI findings. MRI finding will be there. Patient, just listen to what patient telling, and just go find out whether patient is having osteoligamentous complaint alone, or nerve root complaint, or spinal cord complaint like myelopathy. Myelopathy features, that is spinal cord features, is a red flag, immediately refer. Appropriate surgery at appropriate time will be a difference between a normal healthy individual versus a crippled individual. Thank you.